So on behalf of Bipolar Australia, I'd like to welcome you to World Bipolar Day and the culmination of our series of presentations and panel discussion. Bipolar Australia acknowledges and pays respects to the Gadigal clan of the Eora Nation, on whose land this panel discussion is being held, and we pay our respects to the elders past, present and future. Bipolar Australia's objectives for World Bipolar Day have been to raise awareness for bipolar disorder, to provide information and pathways to access support. We'd like to thank our presenters for their time and support for the Bipolar Australia in meeting these objectives, and note that the presentations, which were all available on the BA website, have been targeted to a wide audience and provide a fantastic range of information from the current research, treatment methods, the historical Australian development of lithium, lived experience with bipolar disorder, and support for coming home with bipolar. Over the week, we've seen some presentations from our speakers tonight. Professor Phillip Mitchell covering off recent advances in bipolar disorder. Professor Gregory Demore, Finding Sanity, the John Cade Lithium and Taming the Bipolar Disorder. Dr. Greg Murray, Self-Management to Stay Well with Bipolar Disorder. And two lived examples through Phil Nield and Bernie Mitchell. And Susana, who's going to cover off coming home with bipolar, information for families and carers. Today's panel will be held in two parts. The first 40 minutes discussing some of the questions raised by the presentations, and then a 20-minute question and answer session based on the questions submitted through the Bipolar website during the registration process. We have an apology tonight from Professor Greg Demore, who was unable to join us, but I'm sure that we'll be able to cover off his questions. So without any further ado, I might start the questions if I may. So the first one probably to Professor Phillip Mitchell. You provided us with a fantastic presentation in terms of understanding the research in genetics and the implications for early detection and intervention. What do you see the next stages of development being in terms of that research?
Thanks very much, Stephen. Really just, I'll initially talk about the genetics work in the presentation for those of you who are yet to see it. I spoke about the recent status of the field. That's been presented at international meetings and is about to come out in Nature Genetics, a very high-profile genetics journal. And the current state of the art is we've now identified, and there's a very large international group called the Psychiatric Genomics Consortium for Bipolar, and that's now identified 64 genes for bipolar. It's likely over coming years this will grow. So what does that mean? Is it just esoteric sort of scientists sort of dabbling around with DNA? I think the critical issue is that this will eventually lead to treatments based on the underlying biology. The more genes we discover, the more we can see patterns as to what's going on. The genes are indicating that they're mostly expressed in the front parts of the brain, the frontal regions, and that's an area we've always thought is probably involved in bipolar. So that confirms what had been sort of other sorts of research in the field. The second is we're starting to get a feel for some of the biology, and one of the common themes coming through is that proteins or receptors involving calcium and calcium effects in the brain seem to be coming up more frequently than expected. So I think the take-home message, Stephen, is that once we understand the biology, and I think this is not going to be tomorrow, this is going to be over the next few years, then we'll get treatments that are targeted on that biology of bipolar disorder. And that'll mean hopefully we get better treatments. And as I outlined in my presentation, I gave a case history of a young woman who, you know, the best available treatments have had minimal effect on her life. So there's really important to improve understanding of biology and therefore understand improved treatments. And I think that's the promise. That's starting to happen across health and medicine in general. The genetics revolution is starting to pay dividends in terms of allowing us to develop targeted treatments. I think for mental health, that's going to take a while, but certainly we're at the beginning of that journey. So maybe that's my main message at the moment.
Sounds great. Thank you, Phillip. One of the other items that you brought up in your presentation was the use of imaging and IFG as another alternative method that's being used for diagnosis. Could you just expand on that a little?
Yes. So the study that Stephen's referring to, we've had a study, and we're one amongst several groups around the world looking at the earliest changes in people at family or genetic risk for bipolar. And the whole point of this research is to be able to identify clinical changes, changes in the brain, as well as genetics that help us to determine which people are at particularly high risk of going on to develop bipolar disorder. We know that for at least half of our patients with bipolar, there's a family history of the illness. So this is one of the risk factors we're aware of clinically, but we know that's not enough. So we're just trying to pin down what are the features that really allow us to develop a very targeted focus group for early intervention. And one of the components of that study has been looking at brain imaging. And you talk about the IFG, the technical word there is inferior frontal gyrus. I don't want to get caught up in the technicalities. This is an area deep in the frontal part of the brain. And we found, and our group was really one of the first to pinpoint this area as being important in people at risk to illness, as well as people with bipolar. And this has come up from other research groups around the world, which is really quite heartening that this seems to be a replicated finding. This is an area that's involved in emotional control, cognitive control. So it seems to make sense as to why this may not be as efficient in folk at risk to bipolar. So with that particular study, we're interested in, can we use clinical imaging, genetic and other findings to target a group that we can then start early intervention? This has become, you know, I think the holy grail for the field at one level. How do we get in early? For schizophrenia, in one level, it's easier because there's a very clear prodrome for schizophrenia that has been targeted in early intervention, and there's clinical programs many in the audience would be familiar with. For bipolar, that's proven more challenging. So the field is starting to think, how do we get in early? Because we know even the first manic episode is very destructive for people. It affects their self-belief, their self-concept. And we know that for some people, there's persisting changes even after the first manic episode. But I think the main thing is it starts to affect people's lives, their career, their training, their relationships. So if we can get in early, I think that would be an enormous benefit for the field. So our group, and we've had chats with Greg about how do we do this? This is obviously complex. You know, do you look at medications? Do you look at psychological training, skills training? So around the world, we're starting to think in these terms. And there may be issues Greg may want to talk on later, or some of the audience questions. But I think we're starting to change from being reactive, we respond to mania, we respond to depression. How do we reduce the damage? How do we stop it happening, or at least minimize the impact before the illness starts to become set and established? So that's where that particular study is coming from. Early days, but really an important direction for the field of bipolar disorder.
It's great to see the work going ahead. Greg, one of the things you gave us was 7 practical steps for living with bipolar. You gave us some really useful tools in there. One of the ones I was interested in was the idea of your relapse signatures. I was just wondering if you could give us some examples of what a relapse signature might be under your 7 steps.
Yeah, great. Thanks, Stephen. And this kind of does link to what Phil was saying about, we think about bipolar disorders first onset, and we're interested in trying to find the early signs that might be useful for people to pick up on, and maybe we could get in with early intervention before you get the first diagnosable episode. But I suppose my talk to this group was more about, once you do have a diagnosis of bipolar disorder, what can you do to live well? And in fact, we have a couple of international studies where we got very, very similar themes. So if you've heard my talk, I emphasize this, very similar themes from people who say, I manage my bipolar disorder well. And so obviously it makes sense to ask them, well, what do you do? And on this particular question, it's about trying to catch and intervene early when people are sliding into episodes. And so the notion of a relapse signature sort of implies correctly that what we're looking for and we're encouraging people to think about is, what are the particular things they notice as their mood either starts to elevate into hypomania or mania, or starts to slide down into depression and there's kind of two levels to this answer. There's kind of a general answer that applies to most people, and that's essentially, we're asking them to look out for the mild early symptoms of, let's start by talking about mania and hypomania. And so we're talking there about obviously elevated or irritable mood, increased self-esteem or confidence, which might show itself in some new projects where you have more confidence to think, oh, I'll be able to do that, I'll be able to fit it in. Then of course the classic one of decreased need for sleep, feeling like you can keep going later than you normally would on a project or in a fun conversation. And talking about conversations, being more talkative than usual, and people might even give you the feedback that you're talking more than usual. And if that gets further up the ladder, people might even say you're interrupting them, or it's difficult for them to get a word in edgeways. So sometimes other people might be giving you this feedback that you're heading upwards. Some people get racing thoughts. They report that they feel that their thoughts are skidding around inside their head very quickly, and it's hard to keep track of what of the various ideas that are crossing their mind. And similarly, at that sort of cognitive level, we're talking about distraction. And then, of course, goal-directed activity. Deciding that I really want that thing. That thing could be a promotion. That thing could be a big chunk of money by gambling. That thing could be a new relationship or a sexual partner, and you just get tunnel vision on those sorts of goals. Maybe even starting to ignore your own sort of standards and values around these things. So that's the sort of general level for mania, and they're the sorts of things that people want to look out for. And if you're familiar with the symptoms of mania, I've essentially just listed the symptoms of mania. But what we mean by relapse signature adds another dimension to that, because you will quite likely have your own version of that. So for example, one of my clients introduced me to this idea, which I then checked with other clients, and a few other people have it. And she said, one of the things that I notice as I'm sliding into hypomania is I start looking in shop windows. And I said, well, that's not an abnormal thing to do, is it? And she said, it is for me. I'm not usually the sort of person who stands in front of the clothes shop window and looks at the new design, this season's design for dresses or boots. But I do when I'm starting to get a little bit hypomanic. I start to look at, I find the clothes compelling. I start to imagine myself wearing the clothes and think that would be good, and can I afford that? And so that's what I mean by a relapse signature. She now knows for her that increase in goal-directed activity that I spoke about before at the general level, for her, what she notices is that. For another client that I had, he really noticed that music had a much stronger effect on him as he was sliding up into hypomania. He loved music. That was a feature of him, but he was able to notice the difference, that music was really seductive for him when he's sliding up into mania. So it's the particulars. So I listed the general features, and many people on this call will know what the parallel general features are of sliding into depression. Again, perhaps sleeping too much, loss of energy, feeling worthless or guilty. Those sorts of general things are the things we want people to look out for. But again, there might be specific things that you've learnt about yourself, and they're probably more valuable than those general ideas of, looking for depressed mood. I had a client once, for example, who, the other classic thing that we're looking for with the slide into depression is what's technically called anhedonia, loss of pleasure. But it's a very interesting idea. It means something that usually is pleasurable for you is not now. It's what I call the can't be bothered's, where, and the classic example for me of that is a client that I had once who said, I knew there was something wrong when I was invited to go and watch my son play football on a Saturday afternoon. And he said, I said, no, I'll give it a miss this Saturday. And he thought, that is so unlike me. I would normally love to do that. Something's not right. And so for him, this was a learning about the personalization of that loss of interest or pleasure. Does that make sense?
Yes, it does indeed. And I think you've given us some great tools and some great examples there, Greg. One of the other, I think, probably compelling points you made is just the idea of the collaborative relationship between the clinicians as well. And I think, there are a lot of conditions where this is a challenge, but particularly for bipolar as well, I guess.
Yeah, we've been thinking a lot about this. We've just some of the people on the call might have seen the recently published mood disorder treatment guidelines that the College of Psychiatrists has put out. And as part of that, we were thinking a lot about the treatment of bipolar disorder, especially in the primary care setting. And as a clinical psychologist myself who works in that setting, we're very conscious of the potential problem. Ideal treatment for bipolar disorder involves both medication and psychological intervention, one of the evidence-based psychological interventions. It may also involve going to a self-help group. It may also involve, counseling or yoga, a whole package of things, right? And what's very striking when you think about that is, well, who's coordinating all that? Now, under the Medicare system, theoretically, it's the GP. Theoretically, the GP is referring someone to a psychologist, perhaps for CBT, and a psychiatrist, perhaps for medication. But we all know that there are some weaknesses in that system. Is the psychiatrist in the habit of communicating to the GP? Is the psychiatrist in the habit of communicating to the psychologist? Is the psychologist very good at looping the psychiatrist and the GP back in when there's been a change that the psychologist has noticed? In my experience, that those communication channels are really sometimes problematic. And I think one of the key bits of misunderstanding, and we really just want to raise this up as a clarification of a potential risk of misunderstanding. I think one of the common misunderstandings is perhaps the person with bipolar disorder imagines that the treating team are in close communication, and they're actually not. Or one part of the treatment team, maybe the GP and the psychologist, maybe they work in the same building and they bump into each other every day and they have a chat. And that might include chatting about this shared client. And the client gets the impression that everyone knows what everyone's doing, but they're actually wrong. The psychiatrist doesn't work in that building. They work somewhere else. The GP's never met them. The clinical psychologist has never met them. You see what I mean? The opportunities for misunderstanding are very important. So in fact, what we're recommending now is really just reminding the patient themselves to check who is talking to whom, what can they expect. So for example, if the psychiatrist changes their medication it's well worth the patient asking the psychiatrist, will you communicate this to the GP and my psychologist?
Yeah, I think it's a very interesting observation, and certainly for the medical profession, but also for carers as well.
Yeah, who knows
It's
what?
this is
Who
their
knows
part of their
what?
toolkit, isn't it? Yes.
Who knows
Exactly.
what is, and I think we can see very simple solutions to this, as long as we're conscious that people may have very different understandings about what sufficient communication is. And I'm not sort of prescribing that. I'm not saying, you know, there should be daily meetings or weekly meetings or whatever, but whoever's on that team should know they're on the team. They should know, and they should know who else is on the team, and be clear about what sort of communication will occur and how. Does it fall to the patient? It might. You know, maybe we'll leave it to the patient. The patient will be the conduit for all this information. That's
Yes.
possible.
Yep.
But we'd better agree on it.
Yeah, definitely. Thank you for that, Greg. Phil, you shared with us your story that you put together with Paul Wade of someone who's had lived experience with bipolar. I think you highlight the importance, particularly of the role of the carers and friends, and your 3 Ls. And I just wonder if you could expand on those for us in terms of what your learnings were.
Yeah, sure. It's excuse me, very much an oversimplification, if you like, and you could apply this not only to the carer but for the person with bipolar as well. So the first one I've got down, I've just identified, is to learn obviously as much as you can about the condition, because you know what you're dealing with is an experience when it's the early stages that you haven't necessarily been through, and you don't necessarily know a lot about it. So what we're doing in this event is something really critical. It's all well and good after the event, and it is really nice to have that early intervention if we can do that. It's really, really important. I guess the thing with learning, it's learning about the condition in general, but something which is probably very pertinent is the fact that everyone is quite different, quite distinctly different. When you look at bipolar 1, you look at bipolar 2, and even within those groups, if you like, it's very, very different. So when you're learning, if you're going to support someone, you sort of do, and Greg mentioned the relapse signatures, you sort of need to know a little bit about the specifics for that person, and they are quite different. Initially, I know for a lot of people with bipolar 2, it takes a long time to diagnose. And for me, pretty much I did lose, I should say, a year of my life to depression. So as far as anybody else was concerned, it was depression. And it wasn't until later in the year that hypomania became quite apparent. Then we started to think about it. And I remember going into my psychiatrist, Mark, and just going through a mood diary, if you like, and suggesting to him, well, it is certainly bipolar 2. As I say, these things, it's important to learn about yourself, but obviously for others as well. I've got listen as well, which is sort of like a check-in if you think of, are you okay? And as Greg alluded to, you know, I would suggest it's a lot very similar to relapse signature. For me, the depression, the same with most people, it's very easily spotted. What is the problem for me? And also, I might say the most damaging or destructive, if you like, for relationships is that hypomania. Because for me personally, I don't see it coming. It comes up from behind me and really gives me a good smack on the back. And all of a sudden, I'm going at 1,000,000 miles an hour. People are trying to get out of my way almost. Excuse me. But in terms of that, and in terms of the carer or the person who loves somebody with bipolar, and you really need to, I think you need to, if you're going to stay with that person, there needs to be a bit of love there, because it's a tough job in a lot of cases. So just checking in. For me, as I say, I can't see it, so I do rely on others and as the point was mentioned earlier, yep, you're speaking over the top of somebody, you're taking over, you're very loud, you're very animated, and a lot of those signs are there. For me, I operate quite unusually. If you talk about that, there's no normal mood. If you talk of that maybe as average, whatever that is, I'm lucky enough to operate above that. And I'm sort of always in a good mood, if you like. But that once that becomes elevated and it becomes, I would suggest, a little bit out of control, it's very damaging for me in terms of my work and my, I guess, my employment as well. So the look after thing for myself, again, I've got to check into myself. I've got to think, oh yeah, what are the things that are, for me, what are the signs? What are those, yep, the relapse signatures. And for others, yep, for them to have a look. But with the looking after, I guess the hardest thing is to maybe pick it up and challenge that person. And not everybody can be assertive enough to say, well, hang on a minute, mate, you need to slow down. Okay, you've been talking now nonstop for whatever it is, a bit like I'm doing now, if you like, so cutting any time. So, you know, it is about just letting the person know. Depression, obviously, that's got its own set of problems as well. I'm easy to deal with when I'm depressed. You don't have to worry about me because I'm not going to get out of bed. Okay. But I think the big thing in terms of looking after somebody is don't leave them. Okay. Whatever you do, because it's pretty clear that by yourself, this is something that can be extremely hard to deal with if you don't take your medication. And often it takes a long time, obviously, to get that medication right. I'm just very interesting to hear Phil talk about genetics. My mum has bipolar 1. And her, the way she goes about things, it's really, really very different. And so that's why I sort of caution against just taking a blanket look at things and say, okay, well, this is bipolar 1, this is bipolar 2. She's very rapid cycling. So she's right over the top and then she's right down the bottom, and it could be months of each of those. Okay, other people it's quite quick. As I say, for me, I'm sort of up there. I'm hardly ever depressed at all. I'm really lucky in that. But it is the up there that's damaging, because I know it impacts on work, and it definitely impacts and has done it on my family. So, yeah, very important.
Yeah, and I think the other things that in your presentation you talk about are the carer's role, I guess, in terms of when you're in the hyper state and then in the depressive state, and what they can do to support you at that point.
Yeah, well, I guess and again, it comes back to awareness of the condition and for that person. But I've got to repeat it again, is you just don't leave them. And it might be that you could come into an appointment with the psychologist, with the psychiatrist, and actually find out what it is, you know, for that person that might be as supportive as you can get. I guess we all... it's very hard to explain hypermania, I think, if you haven't had it. I think we've all got to a degree, a little bit of an idea about depression. We've all been sad. And I think depression is perhaps easier. A person with bipolar who's depression is easier to support, I would suggest. But a rattling train going down the track that's out of control, it's much harder, much harder. And I think the thing is, it is the early intervention and try and cut that off. And that might be that we're looking for a change in medication. It might mean, you know, we talked about I think it was Greg talked about yoga. What are the things which actually stabilize the mood? And I think that's another discussion in itself. In terms of an intervention, you know, what do you do to keep somebody on a level mood, if you like? And I know for me, things like exercise, I've just started to look at a little bit of mindfulness in terms of just giving myself 5 minutes a day and just making myself slow down. So if I'm fairly high, if you like. It's taken me a long time, which is, I guess, 10 years for me. It's taken me a long time to actually, with the help of others, recognize those signs and actually be able to do something about it. Okay, so it might be there, but for me, I'm in such a good mood, who cares? And I remember going in to see Mark at one point and saying to him, look, you need to bring me down. I'm just too high. And his response at that time was that that request was quite unusual because everyone's having such a great time. Why do you want to come down? You know, and it is like that. Everything's fantastic. And you don't see the negative aspect of that. Or just, yeah, it's all roses and away you go. So
that's great. Thank you, Phil. Thanks for sharing your experience. Susana, we've heard from a number of the speakers talking about, I guess, the need to learn and also understand bipolar. I guess your experience in Australia was that one of the big areas that was missing was information. And I think in your presentation, you share some of the materials that you thought were required. So perhaps you could share with us just your thinking in terms of those materials and coming home with bipolar.
Thank you. Yes, that is true. When having been diagnosed with bipolar myself, at some stage I needed to the need of going to a support group, and that's when being there, because it was an inclusive support group where carers and people with the lived experience were sharing with each other. Soon enough, I started to facilitate this group, and I've been with this group for 15 years. And I call it a little bit like my informal research, because that opened my eyes to so many different situations. But one was very, very constant. And that was that people with the condition, they always said, I wish my mother carer friend understood something about me, that they can accept me a little bit. And on the other hand, the carers were saying, well, no one explained to me what the condition was or is. How can I help my loved one? Because I may say the wrong thing, which in fact, there were sometimes the carers thinking that they were going to say the right thing. Actually, they, like, I give you an example. Sometimes, not knowing that it's a chronic condition and that people need medication. So as soon as they saw them being okay and being well, they just brought that idea that, well, look at how you now are feeling and behaving, you're doing really well. What about, do you really need to take the medications? It's a little bit like, well, your infection is gone, then do you still need the antibiotics? So it was an obvious gap there, an enormous gap there. My philosophy of care coincides with everybody there, that in my opinion, the closer the team that is helping the person gets in terms of communication, the easier it is to actually help the person. And the way I see it is that if the psychiatrist, the psychologist, the nurses in hospital, and the families, they actually, from their position, they do their work, but then they connect with each other and they communicate. Everybody has a fantastic perspective from where this person comes from. And either sometimes the peer, like friends, that they see this person, sometimes in different moods, but they don't know what it is. So the more they know, the better. So I decided that something had to be done. And with the help of a group of people that actually they've gone through the experience, some people living with the condition, some carers, psychologists that also has the condition, and psychiatrists helping us to prove that we were not sort of maybe saying something that didn't sound good or didn't, it's not the right thing. We developed this booklet. But we thought there are lots of books written about bipolar. This has to be a bit different. It needs to be concise, practical, and a bit like bringing stories that people can relate to. And that's what we did. The book contains the story of 3 situations. Some are families. In one case is a friend looking after someone. So the different situations, and the idea is that is a one-stop shop that you will have a complete information. The part that I particularly like is that it's got some charts where it says when you see the person doing this, maybe you should be approaching this way or that way. So it's like a little bit of like letting people know that if there is a symptom X, maybe you could help this way. And also not this, I was, hoping, and I think it's working, will stop that constant, the roller door of going back to the hospital, because people not knowing what to do at home, as soon as the person presented with something a little bit unusual, that probably maybe with a visit to the doctor or the psychologist could have been solved, and even themselves at home with a carer. But because they didn't know, the thing to do was transport the person back to hospital. And that was, I don't think that will benefit anyone that could do that at home. No. So yeah, that was the reason.
And Susana, where can people access copies of that book, either a soft copy or a hard copy?
Yes, we have a free copy to be read on our website, which is bipolaraustralia.org.au. It can also be downloaded for $10, and it can be sent by post, and that is $15, including the GST and the postage. Now, this booklet has been just recently translated professionally into Chinese, and that was very well accepted as well. But at the back of this book, also what we have is some links that will take you to the Multicultural Mental Health of Australia, and they have a kit that I know because I was involved. They develop a kit of 10 different conditions. They have in a CD, it's 10 different conditions, but separate flyers in 22 languages. And that was done in conjunction with SBS. So it's very easy. Someone the other day called me and say, I cannot find a resource for my mother. She doesn't speak much of English. Can you help me in Greek? Something with some resource. And it took me like 2 seconds because I know where it is, and I just copied the link and I sent it. So the lady was very, very thankful. But also I think that we need to let people know that that exists. And also to let people know that the translators on the phone, to talk over the phone, also exist. And I know because I have done it myself with people. And I think that the concepts we are discussing with a person are very, very important to be fully understood. So it's not a matter of like, yeah, maybe more or less. And sometimes the person, because they don't want to feel ashamed of not speaking the language, they might say yes, yes, and they don't understand what they're saying, or they've been asked.
No, that's it. I think certainly the presentations we've seen so far, it's a complex issue and access to information is pretty critical. So thanks for Susana. We might now just go on to some of the questions that people who've gone onto the website and registered have left for us. And if I can ask the speakers if they would like to address them, if they could just put their hand up. So the first one is from Ben, and he's asked, what is the best support to provide for loved ones who are suffering from bipolar? And is there hope that one day the patient will function like everyone else in society? Nield, Phil, did you want to have a go at that one?
It's interesting, the thing about functioning normally. I've got a quote from my son, and I'm just trying to think of the actual words. And he said something about somebody with bipolar disorder doesn't necessarily do things which are acceptable in society. He was talking about me. So in terms of being accepted or being normal in society, I think that's a given. That is, and as Phillip said, in terms of the genetics, I'm looking forward to developments in that area, because we can always, I guess, improve the thing, but it does depend on them seeking care, the person seeking care. I'm just thinking of the number of people, incredible number, who actually don't have the support, who don't have a psychiatrist, who don't have people to support them. I think that's where there's an issue with, if you want to say, fitting in. There might be non-compliance with medication or whatever. I mean, that's a real concern. So I think from a support perspective, I think society has a responsibility, if you like, perhaps to just be more aware. I mean, and that's what we're doing here. But again, it really comes down to the connection. And I used the word love. And I think the closer you are to someone, well, the more power you've got in terms of trying to make a difference. And I think those connections are really, really important. What do you do there? I don't know. I think Susana indicated about the support groups. I think they're really well worth it.
Okay. One of the next questions comes from Paul, and he's asked, how is research progressing regarding treatment regimes and genetic understanding of bipolar? And then secondly, what is the best user-friendly description you could suggest for bipolar disorder when explaining it to others?
Maybe I'll start the answer to that one. I think my comments before addressed sort of some of those issues, Stephen.
Yes.
I think maybe the issue, I just want to make a brief comment that our current treatments, both medicines and psychology, can make a huge difference to most people's lives. So while we're wanting to improve treatment, so we know they have their limitations, I think the bigger issue is one that Phil alluded to, that most people don't access high quality care. And I think high quality care and that mix, and I agree with Greg, I think the best quality care is a mix of medications and skilled bipolar psychology treatments. It can make a huge difference for most people. So we shouldn't underestimate what we have to offer at the moment.
Greg.
Yeah, I agree with everything that's been said. I just wanted to go back a step. There is a great website for people, of carers of people with bipolar disorder. It's called bipolarcaregivers.org. So just Google that. It's put together by a lovely group of people here in Geelong in Victoria over a number of years, and caregivers tell me it's great. In terms of I just wanted to chip in. I completely agree with Phil. We do have treatments that work. And I agree with the other Phil that you learn more about your own bipolar disorder over time, and people often get better at managing it over time. So we can be optimistic with our current state of affairs without any radical, discoveries that maybe the genetic research Phil was talking about could lead to, right? And then I just want to say one more thing. I think the particular way the question was worded, I think the word normal was in there. And I always have a bit of a reaction to that. I think society, in the same way as society needs to be informed about bipolar disorder, I think we'd all agree that society needs to be tolerant of lots of varieties of people. And there are strengths that go with bipolar disorder. There are serious vulnerabilities, as Phil Nield has already described, but Phil Nield also described himself a minute ago as someone who's temperamentally pretty up and energetic a lot of the time. And that makes him a little bit unusual, but it's a strength. It's a great quality of his. And, there's lots of other features of the sort of person who has bipolar disorder that are great strengths. And so I just wanted to make that comment that we don't all want to be the same. And another way of thinking about this, a colleague of mine in America says, yeah, the way I think about it, a lot of people are kind of like daisies. They're nice flowers, and they'll live anywhere, and they're pretty robust. And people with bipolar disorder are like orchids, kind of a bit special and unique. They might need some special conditions, but you give them the right conditions and you actually get something really cool.
Yeah,
So
I think there are some very high-performing personalities around the world who have demonstrated that.
Absolutely. And I don't want to buy into a sort of polarization of, it's a good thing to have, or, it's just a disease. I don't think that's a useful sort of polarization, but it is useful to point out that people are people. Everyone has their own strengths and weaknesses and challenges. I could tell you what mine are, and Stephen could tell you what his are, and we're all just different. So the whole notion of, can we get everyone back onto the main road? I don't think that makes sense psychologically or in terms of humanity.
Yep. Susana, thanks for that, Greg.
Of course, I fully agree that this will be the ideal world, right? Unfortunately, it's not the ideal world for many people here in Australia. I was talking to my doctor. She's very interested in bipolar, but also in general mental illnesses. And she said to me, Susana, sometimes I want to refer a person I have in my room, and I call rooms myself to the psychiatrist. And we don't have psychiatrists that will be bulk billing, for instance. We're talking about people on a disability pension. They can't afford the gap, for instance. I just found one service that today I actually contacted, and I sent the email because I thought I found one service that they actually bulk bill, and you can see constantly the same person. It's not like if you go to the crisis team, yes, they won't charge you, but the next time you see someone, it's another person. So the consistency there doesn't exist. So we need to find also that kind of balance of, yeah, ideal world exists. How can we achieve it?
No, definitely. I think that's a great point. Thank you, Susana. One of the presentations, and Greg Demore couldn't be with us tonight, he sent us an apology. He gave us a great history of the development by the Australian of lithium as a treatment for not only bipolar, but broader mental health issues. There's a question here that come in from Lucia. I've been taking lithium for 10 years and I'm 47 years old. When can I stop taking it, please? You would like to, Phil?
I'll have a first go at that one. Look, it's a difficult question, and people differ in terms of how you answer that question. For some people, maybe if they've had a first episode of mania and they're on lithium for 6-12 months, it probably is reasonable to gradually come off it and see if you can function fine without it. I like lithium. I think it's a very good medication. Not everyone can tolerate it. It's probably our most effective medication for bipolar. I think other people, lithium allows them to just get back into life. I think lithium, more than other drugs, often has a fairly clean response. It's a strong, robust benefit, not partial like a number of other medications that we have. And some people do so well with lithium that they feel they've overcome the illness. And I've had so many people, I've had that discussion, and usually I say, look, you've got to make the call yourself, and I'm happy to see you if it doesn't work out. And for some people, they have to come off it and see if they relapse. If they do, they come back and say, you know, I'm convinced I need this long term. I think it's complex. It's different for individual patients. But I think when these medications work well, they can allow people to get back into life again. And then it becomes an issue, how long do I stay on it? And I think you need to work it out with someone who understands your illness.
Yes, Greg.
I was just going to ask Phil Mitchell a question. Phil, thanks for that answer. Do you think we have good guidelines for clinicians about helping people come off or trial or investigate the possibility that they can come off their medications? Do you think that's well known, what the sort of general principles are? And
Look, Greg, probably not. And it's not the most straightforward sort of question to answer. I struggle with this with many patients I see. If, for example, if I'm not convinced about the diagnosis and I think somebody should never have been on lithium in the first place, or it's very questionable, that's an easy answer. I'll say, sure, I'll help you come off it. We'll see how it goes. I think the tricky thing is, if you've had someone who has had 2 or 3 quite serious manic or depressed episodes that have been well for 5 years, is it worth coming off lithium? And that's sort of, it's ambiguous.
Yeah. We don't have much data, do we, to help guide the decision?
We don't, and it's they're hard studies to do.
Okay,
I often err on the side of saying to people, look, we'll need to understand if you can do without it. If you come off lithium, you need to do it very slowly. I normally would withdraw over a few months. We know that if you stop it, say overnight, which some people do, the chance of going into a severe manic episode in the next few weeks or next few months is very high. So I suppose one of the messages, if you come off lithium, you need to do it slowly, and you need to be doing it in conjunction with your carer, with your caring clinician.
Yeah, I think Phil would like to add to that, and also Susan as well. So Phil, would you like to go first?
Yeah, I just wanted to give a little bit of an idea just from, again, it's from my experience in relation to medication, because, and I talked about the fact that, for me, it was a long time depression, and then the hypomania kicked in. It really took, and I must say, I felt a little bit like a guinea pig, because we tried this, we tried that, and we tried the other, and it was the dose, this in combination with that, and it is really difficult to get it right. I remember having blood tests to check levels and things, and after 2 years, I thought, yep, Mark, we've got this right. I think that things are stable now. I was wrong. So, other things came into play perhaps, or for whatever reason, we didn't quite get it right. Now, I can say now that I'm really stable. It's fantastic. I'm very lucky in that, but it did take some time. It did take persistence, and I'm very grateful for my psychiatrist for just, I guess, working with me on that. And I'm also very, very pleased that I was accepting of the situation. So, okay, well, that door closed, let's try this. And I think, and this is where the carer comes in, if you like, but it's also information which should be imparted to the patient. And I think it is. Okay, we're going to try this, and we'll see what happens. And it is almost a bit of an experiment, if you like, but I'll tell you what, it's so good to get it right. Yep, so good to get it right.
Okay, Susana. Thank you, Phil.
Yes, what I wanted to share is that I have the experience of, together with the doctor, we were thinking that maybe I could reduce a little bit of my antidepressant because I was taking a little bit, I mean, the dose was a little bit high. And we started just with 1/3 of the dose in the morning only. And I still remember soon enough, 15 days on the dot, when probably that bit of medication stopped working. It was Mother's Day, and my family took me for a celebration. And all I asked them is, my present, please take me home, give me a cup of tea, and that will be the best present on the day. And I just decided I'm gonna go back to my thing, and I'll call my doctor tomorrow and say, and I did say, let's not play with that, because it's been proved that that's what my brain needs. So let's give it to it, and I'll be happy. So no more playing up with ups or downs. So obviously, when someone was just saying to me, well, that shows that the medication is working.
Great, thank you, Susana. I think we're close to the end. I know that Philip's got another engagement. There was one more heartfelt question, I think, from Geraldine that we should raise. And I think this is probably for, as a carer, probably a cry for some thinking. My son has had a late diagnosis with bipolar. He's highly intelligent, gifted, creative. I'm a single mum. I'm overwhelmed because I can't understand how I can get him to get his act together. He can't find a job even though he's very good. Help me, how do I support him? I need help myself. I'm totally exhausted with this complex illness.
Mm.
So would someone like to just put their hand up on that one?
Yeah.
Yep. Phil?
I think really the answer is that you can't do it by yourself. That's the obvious answer. I mean, she sounds like so many other people, and I know that, you know, for my carers, if you like, they've had the same situation, and there've been a few of them, not a single mum, but a few of them. They've all felt, I mean, including, I would go as far to say, despair, if you like. They're just running out of ideas, they're running out of energy, and they're running out of patience, if you like. So for me, what I would be doing is contacting, I guess, I mean, really, that bipolar caregivers sound like a great idea. Contacting Bipolar Australia, I think, that's a good start. And if I could emphasize the fact that, just to recognize that you really cannot do it by yourself. It's just too hard. Go and get help.
Yep. Philip or Greg, any other points? Yes, Greg.
Oh yeah, I completely agree, Phil. Get more people involved. Sounds like the woman herself is feeling a bit overwhelmed and tired, and understandably. So one strategy might be for her to personally go to her GP and get a link in potentially with a psychologist, and that is the problem that will be discussed. Is the problem that her son has a serious and sounds like quite acute illness that's getting in the way and is overwhelming, and she needs time and space to be able to talk through her options, right? So there's no quick fix. It's not going to be one chat, but she does need to, as we've already said tonight, upskill about what is bipolar disorder, what are the likely outcomes. As Phillip Mitchell has already said, we have good treatments that work for many people, but as everyone else has said, as Susana has said, sometimes it takes a bit of effort to get it set up, and as Phil Nield has said, it takes a while to get the medication right. So it's a bit of a journey, but there are steps and there are people who will help, and I'm just thinking about the best setting to start that discussion. And one way that I'm familiar with is be in a room with a skilled professional who understands the topic, and you talk to them, you'll get some support, you'll get some information, and you'll then start to connect up with the mental health networks in your particular area, because it does differ by area.
That's great. Thank you, Greg. So I think we're at our time we allocated. I think I'd like to thank our presenters, our production partner Jessie at Zabarkan, and our CEO Susana for their support for the World Bipolar Day initiative. I think it's been a great event over the week. Just a reminder that all the presentations, this panel discussion, and the questions that have been posted on the website will be available via our website. And as Susana said, that's bipolaraustralia.org.au. And if you'd like to become a Bipolar Australia member, you can do so through the website as well. And as Susana said, there's also access to the information packs through there as well. And we'd like to thank you all for your interest in the bipolar disorder, and we look forward to working with all of you in our community. Thank you very much.